İyi akşamlar, everybody. We have a very interesting panel here. I have two young experts. This is Oktay when I met him a few months ago in Cerrahpaşa. And I was in the kindergarten, urological kindergarten. And we have on the other side Barbara Padilla, who is an amazing urologist in Tenerife and Canarian Island. I think, Barbara, can you hear us? Can we have...
Bağlandık mı arkadaşlar?
Hello.
Hello.
Hi.
Hola, Barbara, ¿qué tal?
Hello.
Hello.
Yeah. Muy bien.
Muy bien. So I'm going to translate, no, I'm just going to keep speaking in English. Barbara is, by the way, one of my Spanish teachers. She improved my Spanish dramatically when I was missing words. Thank you again very much. So do you see the slides that I present? Can you see them online?
Usually, yes. Now
Okay.
they are pointing on you, but they're focusing on
Okay,
you, but
good.
I usually
So,
see. Yeah.
and please, this should be like an interactive session. So it's like, pretend we are in clinic and we have a difficult case and we're going to discuss all together. So when we cannot reach this conclusion, I will ask our experts. Is it possible to have like a split screen, one with the slides and one with Barbara? No, probably not. Okay, so this is the one easy question. This is just to test to warm up our experts. So the first question that we ask everybody is when should we start incontinence? Talk about incontinence with our patients. So Oktay, this is just a very short questions, almost firing. So when do you start addressing continence problem in a patient that has prostate cancer, for instance?
In the first control, of course, we should talk with him about the complications, and first of all, the erectile dysfunction and incontinence. But about the treatment, after we take the catheter out, we will advise him pelvic floor muscle exercises and other conservative measures till 6 months.
Just a question, I'm not familiar with your practice currently. Do you do radical prostatectomies as well? Or you don't do oncology?
No, I'm not doing radical
So
prostatectomies.
they are sending you the patients
Yes,
for this?
yes,
Okay.
yes.
Barbara, what about you? When do you think is there any room to start talking before the surgery with our patients about incontinence and impotence?
I usually begin telling them before the surgery that these are quite common complications, and I explain them why. So I take a picture of the pelvic area and tell them, okay, we are going to cut here and there, and this is why we are very close to the muscles and to the nerves, and this is the reason why you can have urinary incontinence or erectile dysfunction after the surgery. So if you have it, don't worry, because it's very common.
Yeah, and I agree with both of you. It's very difficult to talk about impotence, erections, dryness when your mind is all in cancer. But because we still have a diagnosis of something that can kill you, and this is the last thing that you're thinking about. But it's the first thing you start thinking when they remove the catheter. Okay, let's go to my next question, which is how bad is bad incontinence? What tools you use to measure the severity of incontinence? Oktay.
Yeah, the severity of incontinence is very important, of course. Even one pad affects the patient's quality of life. That's why we are thinking about the no incontinence. It's the primary aim of for these patients. Otherwise, a droplet or some incontinence in a day, they are all affecting the quality of life of the patients.
Barbara, what are you using to assess, what the tools available to assess the severity of incontinence?
I agree with you that it is important to know the grade of bother of the patient, that you can ask him directly or you can use a questionnaire. But also we use the pad weight test. So I think that the amount of leakage is important to decide the treatment of the patient.
Oktay, what type of pad weight test are you using in your practice?
What type?
Yeah, of pad weight test.
For clinical investigation.
For the patient, the everyday practice.
You mean?
You use the 1 hour, 2 hours,
1 hour
24
pad test.
hours?
Yes. I'm using the 1 hour pad
1 hour
test.
pad test. Barbara?
I usually ask them to take the pad for several days, not only 1 hour.
7 days pad weight test.
5, 7, more or less among the days that they can do different activities. We know that if it's only with a big effort or what is happening.
You're talking about the number of pads they're using 7 days or the weight?
Well, both things, but I'm most interested in the weight because perhaps he uses 5. But it's only a little pad, and if he has got a little leakage, he changes, and finally it's 100. Right. So it's not only the number, but the weight.
Is there any special number that you're using, Oktay, in your severity to define severe versus moderate?
More than 5 pads means severe incontinence. But
5 pads, so you're using the number of pads.
Yes.
What about you, Barbara?
But
sorry. Go ahead. Barbara, just a second.
As Barbara said, the weight of the leakage is very important. That's why the PET test is more important.
Barbara, what are you using as a cutoff for severity?
Well, here in Spain, we have like so to say a consensus between people in functional urology that 100 grams would be like a mild severity, no, incontinence. Between 100 and 400, moderate, and more than 400 is severe. Yeah. That's what we are using here.
Anybody else here among you using something else? Other diagnostic criteria? Please go to the microphone.
As far as I know that but please let me speak Turkish. Biz kendi kliniğimizde thank you. Biz kendi kliniğimizde ve uygulamada 2 PET'ten fazla kullanımını normal bulmuyoruz. 2 PET'e kadar olanı sosyal inkontinans olarak kabul ediyoruz. Kabul edilebilir değerlendiriyoruz ama 2 PET'i aşıyorsa bu hasta tedavi gerektiriyor.
Açıkçası ben kendi pratiğimde, in my practice, mesaneyi ilk boş olduktan sonra bir miktar dolduruyorum. Hangi hacimde stres manevralarıyla ne kadar kaçırdığı da çok kıymetli. Yani her zaman PET'i ağırlıkla teraziyle tartıp ölçmek çok mümkün değil. Muayenehaneye ve ofise gelecek bir doktoru hangi hacimde, yani 50 mililitrede ayakta öksürtüyorsanız, penisten akıyorsa bu çok önemli bir idrar kaçırmasıdır. Yani hikayeden, öyküden çok gözlemin çok daha değerli olduğunu düşünüyorum.
Bu bir şey ekleyebilir miyim ben de? Bu konuda tabii şöyle.
Can you please speak in English so she can understand as well?
Okay.
Is it possible?
There is some modifications with this weight of the PETs because for the sling surgery. It affects the success rate. That's why some centers using that for mild incontinence 200 or 250 grams. Above this 250 grams is severe incontinence, and you can choose some other sling types or for other groups. the other sling types.
Thank you. Oktay is bringing a very important concept now that severity requires a titration of the treatment that we can offer. It's not the same. You cannot do one surgery for all the incontinent patient, but you can actually use the severity based on the outcomes, as you said before.
Yeah.
So some slings work much better with the mild incontinence.
Yes.
Sphincter works much better with severe incontinence.
Yes.
Sorry,
Stefano.
and what about Eurocondom? Because can you quantify the leakage as well as the pathway test? Because sometimes, you know, physiotherapists say that the Eurocondom can not inhibit the patient to try to attempt to contract the pelvis to not leak.
Yeah,
What
that's
do you think about that?
That's a great concept. Barbara, do you want to add something to this?
Well, I have no experience, but I think that it could be also a good alternative.
Yeah, I don't think that there is anything published on use the Texas catheter, for instance. The problem is the price is much more expensive than the pathway test. And the second problem is that a lot of patients with severe incontinence that they are already using the condom catheters, they use this also as a tool to urinate because it's comfortable for them. Rather than go to the public restrooms, they use this. And some of them, they develop some like rashes because of the glue that is used in this. Let me give you my perspective on how I'm evaluating the patient. I do use the 24-hour pathway test. I think it's the easiest thing to evaluate the severity of incontinence. I don't rely on the number of pads because this can change. You have like a top businesswoman or a man that is obsessed with the idea of having a single drop of urine there, and it's going to change like 10 times a day. Or you have like somebody who is less obsessed with this, and is going to use one pad, but it's going to be soaked wet. 24-hour pathway test is easy to do because they put the pads in the Ziploc, so it's pretty clean. They bring it to the clinic, they bring a dry pad, I measure, and I have the difference. So in one day, it's sufficient. 7 days will be a lot of Ziplocs to bring in the clinic, and the patients are a little bit grossed out by having this. No? So in one, like a simple 24-hour pathway test, it's a good criteria to evaluate the severity of incontinence. 400, 500 is my criteria for severity, but that's not enough. I add other information, like how does the sphincter looks like, how does the urethra looks like. These are all important things. Can the patient still interrupt the stream? So to have a basic physiology information of this patient. I think that they did pretty well. This is just to warm you up. No? Now we are going to go to a real case, okay? This, can you show the slide, please? This guy here is 75 years of age, and it's actually, I'm always amazed what a Halloween new type of mask can do. This is me trying it and getting ready for our Halloween parties in this picture here. So what happened with this patient, 76 years of age, who has hypertension on 3 medications with so-so control of it, diabetes, heavy smoker, and has a moderate LUTS. So he gets up at night to urinate. He's not very happy. He has to push a little bit. IPSS 15, so not very good. Quality of life 4, so he's not very happy with this. And has some sexual activity. He can have sex once a week. So what would you offer to this patient? What type of assessment would you propose to this patient? Oktay, I come to your clinic with my Halloween mask. You see me there. What would you ask me to do?
Hypertension on 3 medications, diabetes, moderate LUTS. 60 grams.
Anybody else can help, please feel free to. Would you ask me to do a Euroflow? You would do a Euroflow?
Yes,
Yeah.
of course.
Okay, I have a
This
Euroflow.
guy is not, he has not undergone any prostatectomy, has he?
Zero
No.
surgery so far. Not yet.
Not yet,
Ah,
okay.
okay.
Yes, autoflowmetry would
PSA,
be
who
okay,
said
no?
PSA? You would do a PSA. Who would offer PSA to this patient?
I would.
Would you prefer a PSA to this patient?
Yes.
Okay, Oktay, can you give me the rationale of measuring a PSA in a 76-year-old guy with a lot of comorbidities?
I would like to know if this patient has a prostate cancer, this change all the treatment. That's why I want to know the PSA level for this patient.
Barbara, why would you ask the PSA for this guy?
I think that nearly everyone does some kind of screening, don't we? So the guidelines say that we shouldn't, but in reality we do.
So Barbara is bringing a very interesting topic, guidelines. You have a question, please. So do you think that, do you see the PSA as an invasive test? Is it an invasive thing to offer?
No,
non-invasive.
no.
You think it's invasive?
No.
To fund non-invasive? Please.
Bu hastada 10 yıllık, 15 yıllık yaşam beklentisi olmadığı için aile öyküsünü sorgulayıp, rektal tüşe yapıp, malign bir prostat dokusu yoksa PSA istenmeyebileceğini düşünüyorum. Çünkü invaziv yani primer küratif bir tedavi yapmanızın gerekli olmadığı bir hasta grubu olacaktır. O yüzden atlanabilir. Ancak tuşede yaygın bir prostat kanser bulgusu varsa erken hormonal tedavi ya da bir tedavi planlıyorsanız o zaman PSA bakılıp biyopsiye gitmeli diye düşünüyorum.
Okay. Any other thoughts about this? Everybody in agreement? So we do a PSA to fund.
Şimdi tabii fonksiyonel ürolog olarak Taha Hoca'nın sözü üzerine benim bir şey söylemem onkolojik açıdan kesinlikle doğru olmaz ama gerçek hayat pratiğine baktığımızda hastalar bunu bilmek istiyorlar ve biz bunu yapmadığımız zaman da bizi daha sonra eksik bir şey yapmakla suçlayabiliyorlar. Dolayısıyla eğer PSA istemeyeceksek de Taha Hoca'nın söylediğini çok iyi hastayla tartışmak lazım, anlatmak lazım. O benim pratiğimde çok uygun bir şey değil, çok mümkün bir şey değil. Dolayısıyla ben rutin olarak burada PSA'yı mutlaka istiyorum. Kılavuzlar bize ne yapmamız gerektiğini aslında söylemiyorlar. Onlar bize literatürdeki evidence'i söylüyorlar. Dolayısıyla her zaman ya kılavuzun söylediğini de mutlaka öyle yapmamız gerek diye düşünmememiz lazım. Hastadan hastaya farklı davranabiliriz. Çünkü bu hastanın başka dertleri de var.
Thank you, Fatih. There's another question, comment.
Tufan'a %100 katılıyorum. Şimdi Ervin Kocjancic'e gelen hastayla yahut da Talha'ya gelen hastayla günlük pratikte genç arkadaşlarımın karşılaştığı hastalar tamamen farklı hastalar. Onlar bu PSA'ya baktırmadıkları zaman başka bir meslektaşları tarafından suçlu ilan edilecektir. Onun için son derece önemli görüyorum ben bu hususu ve dolayısıyla günlük pratikte bizim günlük algoritmamızdan şaşmamamız gerektiğini düşünüyorum.
Okay. I'm checking PSA for this patient, regardless of, although we, after 71 years old, based some guidelines or some research, we don't need it. But because of legal things, because we don't know the previous PSA before 71 years old, I'm checking PSA because after we don't know what will happen. And in our culture, because one drop of urine is very problematic, and they are using, as you said before, the condom catheter, because they cannot pray if they have leakage. So for this case, because he is diabetic, I'm checking the residual urine, I'm checking uroflowmetry, and I should be take care of result of surgery after. Thank you.
Thank you very much. I really love you guys. You are so amazing. And I really know, can you go to the slides, please? Slides. Okay. I know my community. I know how to trigger you. And I offer you the PSA. I know exactly that you were going there. So this guy had the PSA of 5. Okay, 76 years of age. We already heard that some sort of age and life expectancy should be taken into consideration in this patient. So what should I do next? Now we have an abnormal PSA. Oktay, what do you do with this patient now?
He has PSA 5
Yeah,
and 76 years old.
yes.
I would like to have an MRI screening.
MRI.
Yes.
So you're going towards the oncology part. Barbara, do you agree with MRI on this patient?
But we have to talk with the patient, of course. And,
The patient, okay, the patient's biggest concern is his LUTs. He doesn't care about the PSA. Now he cares because you order a PSA, so
Yes.
you put in his mind that he might have a cancer.
That's why we should continue.
That's why we should continue. Barbara, do you agree with this? What should
Well,
we do?
I agree with what one of the persons in the public said before. Sorry, I don't know the names, but I think that in the first visit it is important to perform the digital rectal examination. So maybe we find a note there or whatever. And this 5 is more or less important depending on this result. Also, we have this PSA of 5 after. So this is the second visit, isn't it? Or visit 1. Well, we had a visit
No, this is
0
second,
and
yes.
a baseline visit and visit 1. No? So maybe depending on the predominant symptoms, you have also told the patient to begin already with an alpha adrenergic or whatever. So I think that we don't have this information now. Maybe you have already begun. And maybe you have also ordered the uroflowmetry that Merit was saying.
Good. So this, can you go back to the slides? Now, these patients get MRI, there was a small nodule, get a biopsy, Gleason 6, 3+3, and get an amazing radical prostatectomy, a robotic radical prostatectomy. Now he's a year out of surgery, and he has a pretty severe incontinence. You can use any criteria, the pad weight, the number of pads, STAMI test, and has no erections, and he's leaking almost a kilo of urine in a day. So what are my options now, Oktay? Well, by the way, the LUTs are gone, so he's good. He's no longer up at night because of nocturia, but he's not up at night because everything is wet around him.
Yeah. His mental status is very good.
Perfect mental status.
Perfect.
And see, he's a little bit angry with you because you did surgery. on
And
him.
all the physical conditions in good. Then I will to order for the artificial urinary sphincter is an option for him. I would like to discuss with him the artificial urinary sphincter.
Oktay, guide me in your discussion. So I come to you, I leak like crazy. So you just say you need a sphincter, that's it, see me in the OR, or you tell me about other options, you're telling me?
I don't understand.
So when I come to the consultation with you, and I have like a severe incontinence like this,
Yes.
so you're focused on the sphincter only, or you give me more options?
Of course, more options, but he has 800 grams per day. It's severe incontinence, and we all know the best option for these patients is artificial urinary sphincter. But before that, we can talk about the other alternatives. I think she had before, right after the operation, the pelvic muscle exercises.
He only had the pelvic floor therapy.
Yes.
He didn't do anything.
Yeah, yes.
Tufan, you have a question.
Hastanın Gleason 3+3'ünden nasıl birden radikal prostatektomiye geçtiği kısmıyla ilgili bir soru sormak istiyorum. Aslında bu hasta anladığım kadarıyla hocalarım beni düzeltsinler. Watchful waiting için ya da yakın takip için uygun bir hastaya benziyor. Dolayısıyla ben böyle bir radikal prostatektomi yapmadan önce hastanın şikayetlerine yönelik fonksiyonel incelemeleri bir kere önceden yapmak isterdim. Bunun içinde mutlaka üroflow değerlendirmesi var. Belki de ürodinami değerlendirmesi var. Bu hastayı da ameliyattan uzaklaştırmak isterdim açıkçası.
That's a great question you're asking. So how did this patient comes here? So the patient had the PSA. He went online. He checked what PSA means. And so now he's obsessed with the idea of having cancer. Okay? So he knows that there is a big chance to having cancer, which was documented on this. And he cannot live with the idea of having cancer into his body. So he found a very compliant urologist who said, yeah, let's just take out the prostate. We are going to cure you. You're going to be cancer-free. And that's the reason why he had prostatectomy. Francisco.
I'm not going to comment
I understand.
if you want, I may try in Turkish. I'm not going to comment the decision for the prostatectomy, which I think it is the example of what we should not do. Right. His life will be miserable from now on. My point is the incontinence is a severe incontinence. And from the master trial, the first and probably most important conclusion that we got from the master trial is that if we define continence by 0 leak per day, we only have 13% of patients dry. Right. So most probably this patient will end up, whatever the treatment, and it will be, most probably, I agree that this patient might be better treated with the artificial urinary sphincter because of the volume, but the probability of being dry is very low. You probably will need to use 1 or 2 pads per day.
I agree. So when to start treating, this is the natural history of incontinence after radical prostatectomy. After the first 3 months, in the first 3 months you gain a lot. But somebody who is leaking 800 a liter right away, there's no reason for me to wait for a year to treat this patient because he has a very severe incontinence. But let's just move a little bit how to manage this. So as we said today, so before to fun, so he had the urodynamic, stable detruser, no sphincter activity, leaks like crazy. It was actually difficult to perform the systematic study because it's constantly leaking out. So it was difficult to interpret it's difficult really to use that urodynamic in any how. But now he comes to you, Oktay, and he says, thank you for the information, but I really don't want to have the risk of that sphincter comes with. I would like to have something less invasive, something that is not, it goes faster. I'm old, so I don't want to keep pressing my scrotum to pee. What should I do, doctor?
We have other options, of course, to offer.
I would really like to have a sling.
The success rate of the slings in such patients with severe incontinence is not so high. That's why the first option is artificial urinary sphincter for these patients. If he doesn't want to have such a device, then we can offer to him sling surgery, but he should know that he will have leakage after that.
So who would convince this patient to go for a sphincter? Who would try to convince him, listen, sphincter is so much better, you're going to be dry rather than doing a sling, which is, you're going to be a little bit better, but, okay, no complication, but a little bit better, yes. Please, very short, because we are running out of time.
Şimdi benim de bir hastadan deneyimden dolayı bir şeyi çok kritik olduğunu düşünüyorum. Şimdi total inkontinan gibi bir hasta bu. Aslında cerrahiye karar vermeden önce bu hastanın mesane kapasitesi nedir bunu bilmekte fayda var. Ürodinamide kaçıracağı için idrar benim pratiğimde benim yaptığım bir foley kateter koyup balonunu şişirip mesane kapasitesi nedir bunu bilmek lazım. Defalarca endoskopik interne üretrotomi yapılmış, vezika üretrale anostomozdan sonra total inkontinan olan bir hastanın ben mesane kapasitesinin 30 mililitreye kadar düştüğünü gördüm. 30 mililitrelik bir kapasitede zaten bu seçeneklerin hiçbirisi doğru değil. Belki ilerlük bile bir seçenek olabilir.
Yeah, the bladder capacity is normal in this patient. The sphincter is
Ervin?
perfect. Yeah?
Yeah. I think that it is important what you have written in this slide. If the patient is already convinced, maybe it's also a bit difficult to offer him another option. I don't know if in Turkey you've got the ATOMs available, this sling with the silicone cushion that you can also refill. That could be an option for him. If he thinks that there's an alternative that he finds better and you offer him the other way, and he has got any type of complication, you will have a nightmare, I think. So that's also a point that we have to take into account. And I agree that I would ask this patient to have an artificial urinary sphincter in my point of view. But it's not only my point of view that is important, but also the patient.
Great.
And also he has got 75 years old, so we don't know the cognitive state of this patient.
Okay, so this guy had a very aggressive urologist. Can you show me the slides, please? So he was convinced to have, listen, with the sling, you're going to be still wet. It's the other one is a little bit bigger, but it's not a big deal. We just prepare a little bit of urethra, put a cuff there. You're going to be dry. You're going to be happy. So he got an artificial urinary sphincter. He's okay for the first few months. And then a year later, he developed dysuria, pain, and intermittent hematuria. So what is going on with this guy now? Remember, he's a very heavy smoker and has diabetes. What is so suspicious here?
Yes, now we have a complication. I would to perform a uretrocystoscopy to see the urethra for erosion.
So what do you see here? You want to comment with us?
Yes, I'm seeing the cuff here.
So this is a first take-home message. Whenever you see any part of the implant, ain't good. So you need, this is a bigger complication, a major complication. You have to remove everything, okay? Yeah. And unfortunately, this is what happened with this guy. So this is other aspects of how you can see an erosion with like this white fibrinous tissues. There are all signs of necrosis. And this is what I found when we opened this patient. The whole urethra is at that level. So we need to remove the cuff, rebuild this urethra, and then wait, okay? We are running out of time. I'm just guiding you through what happened with, these are real cases, by the way. What happened with this guy? So we removed the catheter. He was perfectly incontinent as before the surgery. But then 2 months after that, he went to the emergency room because he went in acute retention. He developed an untractable obliteration of the bladder neck that was treated first endoscopically, then was recurring on a monthly basis. So he underwent then to a robotic perineal bladder neck reconstruction. And also this didn't work because after that he wanted to have another system for continence, which actually caused a complete necrosis of the urethra. So one of why I built this story, first of all, nothing that we are doing is non-invasive. In my country, even a PSA, ordering a PSA test can be considered as a very invasive procedure, as in this guy here. He has a very insignificant prostate cancer, which he could live perfectly without knowing about it. That's why when we order a PSA test, we write that we inform the patient why we are ordering it. It's nothing, simple test can be very dangerous, as was in this guy. But my really take-home message is this. If you ask the patients why they prefer, it's very different compared to what we suggest the patients to treat for their incontinence. This is published this year. And look at what they found. If the surgeon was suggesting an artificial sphincter, still the majority of them would go for what the surgeon would say. But they still think that they should have something else. But if you just ask the patient what they want to have, they don't want to have a sphincter. They want to have something non-invasive, something that's easier to use, despite the fact that they have the knowledge that this is going to be less effective. So take-home message for this patient is there are new options that we have rather than sphincter that you need to use, you need to discuss. We started with this. How thoroughful are you with discussing all the options with your patient. The silicone-based products are not very good underneath the urethra because on the long term, they can cause permanent damages there. The non-mechanical devices are what our patients prefer. And we have to listen to them. Because now this patient who ends with the colostomy, with ileal conduit, to treat something that he didn't even have to know, we didn't do a big favor to him. So my very last slide, and I would like really to thank you, you were amazing, because you participate so actively, is listen our patients, listen what they want, and give them a real informed consent, also for things that we gave for granted, like offering a simple test like a PSA. Thank you very much.
Thank you.